Thank you so much for all of you being here tonight. I'll just briefly introduce myself as Lisa Lima, a program director with NAMI, and Chris Adcock as development director with NAMI. So this is a C.A.R.E.S event, wherein C.A.R.E.S stands for Community Advocacy, Resources, Education, and Support. So it's an informal discussion about mental health, and we do this across the 9 counties of Southwest Iowa. So we also provide support groups, educational classes for individuals and families with members of mental illness. And we just want to normalize the conversation. That is kind of NAMI's goal of erasing the stigma with NAMI. And I appreciate all of you from Heartland Family Services for being here tonight. Thank you so much. Rita, can you tell us about the ACT program?
I can. I'm Rita Million, and I am the team lead for the Rural ACT program. And this is Terry Witt. Terry, I'll let you just say a little bit about yourself, and then that would be just a minute.
Thank you.
I'm Terry Witt. I'm the assistant team lead for the Potawatomi County ACT program. Let's see, our program's been in existence for a little over 16 years, and I've been with the team for 15.
My name is Jimmy Yeck, and I work part-time with the rural team and also part-time with IHH. I've been a peer specialist now since 2007. So I got my national credential with Mental Health America in 2019.
So to answer your question, Lisa, the Rural ACT team stands for Rural Assertive Community Treatment. And so what the Rural Assertive Community Treatment, or ACT program is that we bring all of the resources out into the community for an individual who has mental illness, who is struggling with some issues, serious illness, or serious issues with their illness. And help them to meet those goals and to overcome those things that are most challenging for them, and help them to identify those goals also. So as part of that team, we have the peer support, which Jimmy represents here. He's going to be on that rural team. And then we also have rehabilitation specialists who will also work with the clients to help them achieve goals. And then we will have a nurse who I will also be the nurse for the rural team. In addition, so I would help clients with their medications, keeping those organized for them, helping them manage that piece. As the team lead, I'm going to manage the team in the sense of making sure what our schedules are, what are we doing. We would have a team meeting every morning where we review everybody's case every day, and we discuss what's going on. And then we've got the whole team is involved. It's not just one person taking care of one person, which you sometimes see in case management. So we really wrap the person with those resources. In addition to the rehab specialist, the peer specialist, and the nurse, we also have a therapist. And then we also have a provider or prescriber. And so for the rural team, we'll have a nurse practitioner, and we will have a therapist. Right now we'll have a part-time therapist just as we're just getting started. So that's what the rural ACT team looks like. Did you want to say a little bit about the council boroughs?
Just in general, the ACT model, because even though the dynamics of every ACT team are a little bit different depending upon where they are, all ACT teams, and sometimes called PAC teams, it's the same thing. PAC stands for Program of Assertive Community Treatment. There's also such a thing as a FACT team, which is Forensic ACT. They also follow the same model. We are all intensive, outpatient, community mental health providers, and when I introducing the program to prospective clients, I tell them that's a lot of big words. That's a mouthful. It's hard for me to remember all the words. But all that means is that ACT was designed to see people out in the community, to meet them where they are. So we spend most of our time out in people's homes, maybe at the peer center, out doing things side by side with people. We are a multidisciplinary team, which Rita touched on that a bit, but we have therapists, mental health rehab specialists. Most teams that have built a census and have grown over time usually have substance abuse specialists, peer support. We even on the Council Bluffs team have a health mentor. In something called In Shape is embedded within our team, and the health mentor actually goes with the client to look at building an exercise and nutrition program designed just for them. Because one thing we know about folks who have serious and persistent mental illness is that sometimes they have some co-occurring physical health struggles as well, and often maybe don't live nearly as long as members of, the general population, up to 30 years less.
Mm-hmm.
And so we want to help, our clients have the same opportunities and the same health care, have the same access to the Y and all of the other things that just the general population has. So that's part of our team. All ACT teams meet every morning. It's our equivalent of hospital rounds. And to give you a little history of ACT, that's how ACT was established. A hospital social worker, I think in Wisconsin, if I'm not mistaken, sort of noticed that revolving door to the hospital for people with serious mental illness, and started doing a little bit more follow-up care with people when they became discharged, and followed them and provided some case management, and noticed that those people had better outcomes and came back less. And so the legend tells that in a bar, that person got together with some of their colleagues and decided to bring that to the community. So ACT is sometimes called a hospital without walls because we're a pretty intensive level of services in the continuum of, mental health services.
And how long did you say earlier that ACT has been?
ACT has been around, I'm guessing going on about 50 years now, probably over 40, most likely.
And I'm asking this because the rural is just building right now, but in Council Bluffs, so how many clients do you have? And is client the right term?
Yes, that's what we refer to our folks as clients, not as patients. We serve, I am thinking right now, about 74. We're probably staffed for about 80. Usually ACT, one of the parts of the model is we look at keeping our ratio at about 10 to 1, 10 clients to 1 staff. We've always kept ours a little bit less than that. We feel like that's how we're able to provide what our folks need. Usually we try to see our clients if the client is willing a couple of times a week, and that means that 2 different staff, each one will see that person once, but we're very flexible according to what that person needs. So they may go through a rough patch and need more than that, and we can see them every day. We may go out and monitor their meds every day, take them their meds, watch them take them. We can give injections. That's why we have nurses. Our prescriber is in our morning meetings every day. So all of us are working off the same treatment plan, hopefully being pretty consistent with what we're doing.
Hearing hospital without walls really helps me understand
Mm-hmm.
kind of what your mission is.
And we serve a particular group of clients that's what ACT was designed for. So we treat people who have a primary diagnosis of major depression, schizophrenia, bipolar disorder, or schizoaffective disorder. They can have other co-occurring things, be it other mental health diagnoses, substance abuse diagnoses, or whatever, but one of those four needs to be the primary. Usually our folks have had previous hospitalizations, because that's what we're designed for, is to keep folks in the community, meeting their goals, doing the things they want to do, and lessen that hospital time.
So important.
Mm-hmm. We alter our treatment plans. It's a client-driven treatment plan, so we are pretty flexible and want that client to participate and try to help them work on what their goals are. When they meet those goals, we're time unlimited, so they just make new goals.
One of the unique things we offer too is that we're available 24/7.
Mm-hmm.
So somebody is on call every week 24/7. So if somebody is having a crisis at 2:00 in the morning and they truly need to reach out, they have access to us that way too.
And we respond by phone. The after hours is not necessarily an in-person response, but sometimes that's all somebody needs, is to have some support, or, have some coping skills to get through that situation, or somebody to help them make a crisis plan. Mm-hmm.
This will be my second stint with ACT, and at the street level, I felt that it really makes a difference in people's lives. You really come in and see the importance. For me, I was all about the recovery model, and ACT, and working with ACT, it gave me a different light and different lens to see the medical model and aspects of the medical model come to light. So I really like ACT and the model, and they value the lived experience voice, and someone that's living with a struggle, but still going forward with their lives and having a quality of life that anybody else in life would want.
Absolutely. And we definitely are a recovery model as well. I mean, we like to see, that's one of, I think, the rewards of doing this work. I have clients that I have worked with for the last 15 years, and I've gotten to see them go from being very symptomatic and struggling a lot to being very successful over time. Having, getting jobs, going to work, maybe having their own family, buying homes, whatever their goal was.
So can you talk, Jimmy, maybe since you first addressed it, can you talk about the difference between recovery model and the ACT model?
As I see it, the recovery model is strength-based, and you focus on people's strengths.
Okay.
And the medical model, I was more versed in it over some of my previous positions, but just the importance of medicine. There's so many things that go into someone's recovery other than just medicine.
Absolutely.
And I call it personal medicine. I think Pat Deegan calls it personal medicine, and the importance of, just having things in your life that are going to help you that aren't medicine related.
Right.
For me, it was actually finding a hobby that I loved doing, and I experienced a lot of healing through being outside, just fishing. And I love to fish and be with my friends, golf. And so just, that's kind of how I see it.
And I think, and you can tell me but I think ACT does a really good job of integrating those models.
Yeah.
We do have a prescriber, but we all come to the table, and that's why we're multidisciplinary, from peer support to therapists to rehab specialists, prescriber. We come to the table each morning as equals. So where the medication is very important, and sometimes that's what it takes to start getting some stability, we're also working on all of those other things with people too. We do our own case management. So if somebody's needing housing, if they're needing to work on getting their benefits, all those things we do, but we also work on socialization. That's what the whole peer center is about, and we really partner with them at the peer center. ACT is in and out of there all the time, so we are trying to help people meet those goals and live a fulfilling life as well. And so it's not, I don't think that everything for ACT is driven by medicine and the prescriber like it probably is if you're just seeing a psychiatrist. You go in and see that person for 15 minutes. It's all about the meds, all about the symptoms. Clearly, we're assessing for symptoms, but many of our meetings with clients aren't even about symptoms. They're about life skills, or if somebody has established good skills, it's about maybe going fishing. I've gone fishing with many clients, so has Jimmy. Yeah, I've bowled with clients. I've done many things with clients. So I think it's a good integrated model.
And just to help people. It's really integrated to really at the street level. It's built. The components are built to really come in and give value to the person and give value to their voice. And so I like it. I like what I get to do.
And when we say we meet people where they are, we definitely do. We go out to the camps. We have lots of clients who struggle with homelessness. I've hiked through the woods a few times. So when I say we go to people's homes, that, that's loose. It depends on, some folks have a home, but if they don't, we go where they are.
I think one of the things that, because I just joined the ACT team in March, and so it was a new model for me. And so one of the things that I find most interesting is the teamwork. They, in the morning, to hear everybody say, well, somebody needs a ride here. Well, the nurse might say, hey, I can do it. So it's not, you're not held to that position. And I think that's the beauty of the ACT program, because then everybody knows what's going on with everybody, and everybody works together on those goals. So to me, you don't see that in all settings, especially in medicine. It's very segmented. I do this, you do that. But here it's all about, what can you do? We'll just trade off.
And a lot of research has been done on that very subject, ACT versus, and my words fail me at the moment, but people seeing a psychiatrist here, a therapist here, and getting all the different components of their treatment in different places. And the research bears that out, that the ACT model and the consistency, people have much better outcomes. They go in the hospital a lot less. So
I think it's in the 90%, isn't it?
Yeah.
Wow.
Well, our days, that's one of our outcome measures. And so, again, to be in the program, people have to have had some psychiatric hospitalizations usually. And so our statistics consistently run at usually 98 to 99% of days spent in the community. And that's a statistic when you combine all of the clients' days for that month. So outcomes are pretty good.
Can you explain that again? So 98, 99% of their days are within the community?
In the community. Okay. So that means that their hospitalizations have been dramatically reduced from the amount before ACT.
Gotcha.
Because many of the folks that we see, it's just been revolving because they never got any stability. They weren't able to follow through for whatever reason, or couldn't get consistent services, or maybe had a hard time staying on their meds when they got out, so they just kept going back in the hospital. And so that's our statistic is usually 98, 99% of days spent in the community.
How does an individual learn about your program? Does it start at the hospitalization? I mean,
Sometimes we get our referrals from everywhere, and we like coming places like this and educating folks about ACT because sometimes it'll be a self-referral. People have heard about us and feel like they need our services. Sometimes a family member, a friend, hospitals refer people, other community agencies, the region refers people.
The regions were open about it.
Yeah.
Mm-hmm. And I've been just out in the community telling different people about the program, and then all of a sudden a referral comes.
Mm-hmm.
So just getting that word out there, it's amazing how somebody knows somebody and they get that information to them. So, and I should say too, because a little bit about the rural, we're going to be serving all 9 counties, whereas Council Bluffs team is just in the Council Bluffs area.
Yeah.
So the beauty now is that we will be able to, and we're all one team, but we kind of, because we have different areas, we'll be away from the Council Bluffs team, but they'll let us come back, won't you?
will it be the same provider and everything that covers all?
Just in the beginning, we have a new provider who's going to start this summer.
Okay.
Hopefully.
But they will also be part of Heartland Family Service.
Yes.
Okay.
So we're all under the same umbrella.
Sure.
It's just we'll be at different locations. And I think the unique thing about the Council Bluffs is that they can have walk-ins, whereas out in the rural community in our offices, we won't have walk-ins because we can't guarantee somebody's there. Currently, we have an office in Heartland that is close to being up and running. We're just waiting for a little construction to be done. And then we're going to have a second office in Clarinda so that we'll have one in the northern counties and the southern counties. So we'll be reaching out to all 9 counties, Monona, Harrison, Shelby, Cass, Potawatomi, rural Potawatomi, Mills, Montgomery, Fremont, and Page.
And their team will grow as their census grows. That's how ours was. We were a very small team in the beginning, and then as our census grew, the team was able to grow. So there's Will as well. They'll staff the team according to, how many clients they get. Usually they say an ACT team probably should not serve more than 100 clients before you look at then establishing a new team.
Gotcha.
A recent study, I think, by the state was done in Iowa, and it was determined that to serve the population and the folks that they feel meet ACT criteria that are out there, that 22 ACT teams would be what is needed. And so that's one of the reasons for the funding for some of the expansion, is to try to meet that need out there. Because right now, I'm thinking maybe 6 or 7 in the state. When I first started, there were only 4 maybe in Iowa.
And I think the goal for Iowa is that they have available for every county.
Yeah.
That is the goal. That every county would have it. So we'll have a large area, won't we, Jim?
Yeah,
It will.
it's
Yeah,
going to be
it's
interesting to see how it all comes about with the rural team. But that's one reason I wanted to sign on, was just something new and, just to see how it all can be at that ground level of something so important that I see.
Mm-hmm.
Lisa and I know about all the miles, between top to bottom. Because I live down near Shenandoah.
Okay.
Right.
I used to live down that way.
Oh, you did?
Yeah, in Essex.
Well, she's in Essex.
That's what I am.
Seriously?
Yeah.
Then you probably know my husband.
Oh, I don't know.
We'll have to talk.
Okay.
So
Maybe, I don't know.
Referral source.
Yeah. Yes.
Yeah. Yeah. That's great. But yeah, there's a lot of miles in these 9 counties.
Yeah.
So many. And just Potawatomi, and just
Potawatomi's a big county.
and the huge difference between the Council Bluffs area and rural. You just immediately jump to rural, I think.
And there's some fairly good sized towns out there like Atlantic and Shenandoah and Red Oak and different ones, but they still don't have those resources that you have in the larger cities. They have to drive up here or over to Omaha or to Des Moines or to Kansas City at the worst, So having this availability of this program out in the rural community could make a huge difference. And especially for those rural access hospitals and the non-access, our exactly, rural access, their emergency room visits and that could decrease, and then they can focus more on the clients that have the other types of nature, more physical needs.
There are so many folks out there that either don't drive or have access to a vehicle or transportation. And so being able to do what we do in the community is, a lifesaver for some folks, because otherwise they would go untreated and unserved. So.
And I've lived in rural Iowa, so I know those needs too out in those counties. So that's what was part of what really made me join the team. But also seeing the team, how it works. I mean, it's just amazing to me to see so many people together, be able to work together like that.
Yeah.
It's so encouraging, and it's something you just don't see out there. So I can't say enough about it. I know. I brought you.
We'll be saying that about your team.
Yeah.
Well, I feel like I've gained a wealth of knowledge tonight.
Good.
Thank you so much for sharing.
Yep. No, I can't think of any other questions.
This is amazing, and I just really hope that the rural team is able to take off, because this is very important.
It's already starting to.
Good.
I mean, we're I thought it would be more baby steps, and then every week it's a little bigger jump.
Is it really?
Yeah. So and when I say that, it's not that we're enrolling so many people, it's just that so many people are reaching out and saying, hey, we want more information. So that tells us that
there's a lot of need out there.
Yeah. So I should just say a little bit about the process. If you know someone who would be a potential referral, you can, on the flyers I have, there is a link, and you can click on that. And if they're in the rural community, you would click on Heartland. If they're in the Council Bluffs area, you would click on that. It gives you two options. And then that referral comes to us. And then what happens is we reach out and we call the individual, and then we find out, where they're at, and tell them a little bit about the program, and then we set up a time to come meet with them if they're still interested, and then we move forward from there. So that's the process.
So does the whole team meet with the individual at one time?
No.
Okay.
Typically the team.
I was gonna say, that sounds overwhelming.
Yeah.
I do. Rita does for her team. She does that first meeting and assessment. I and Haley Roth, who's our team leader, and I'm the assistant team lead. We, just depending on which one of us gets the referral and is available at the time, we'll do that initial contact. And then our process is, if we feel like that person might meet the criteria that Medicaid says they have to reimburse, they then have a meeting with our prescriber. And so it's kind of a 2-meeting process, and we then see if we can get approval from Medicaid for the person. But one good thing about working for Heartland is that even if they don't meet the criteria for ACT, we have many programs and we all work together, so we can usually make sure that some services are available to the person if they want them. Mm-hmm. We just got, our agency just got a grant for, you probably heard me mention CCBHC.
Yeah.
Jimmy, help me.
Community Behavioral Health Clinic.
Yeah. Oh. And so that, rather than being a pretty convoluted process of having to be referred and assessed by numerous programs, that's kind of an access door to everything. And so if somebody has a mental health issue, they can see a navigator and a case coordinator who all office out of Peer Center over here, and that person will help hook them up with all the services. So that's one way that people can get to ACT. Rita talked about the online way. You can call us.
Yes, yes.
Call us.
Yeah.
You can, for Pike County, you can come to our office. I mean, we're very flexible and informal. You just get in touch with us and
We're quick at reaching out.
Yes, we are.
Yeah.
You can come to our parking lot and look like you need some help, and I will come out in the parking lot to you.
Yeah. And I can attest to that.
So you've been known to do that?
Many times.
Oh my gosh.
It doesn't even have to be our parking lot. If I'm passing you on the street and don't have another client in the car, if you look like that you might need some help, I'll come talk to you.
Oh my gosh.
She's my mentor, so I'll be doing that.
Now that's scary. That is scary. But no, we want folks to get what they need. And it may not be that everybody needs ACT, but we know where the services are and how to get somebody in the door.
Right. Yeah. Amazing resource.
It is. And I didn't even know you existed.
Now you do.
I do, yes. This is amazing.
And I hope this helps tonight to get the word out.
I feel like it.
People feel more comfortable with us too.
And we're happy to get to know you. We love learning about resources because that's one of the things we do is to help clients and family members know what's out there and be part of the community. And
be a clearinghouse of information.
Absolutely.
Right? You can use that word too.
Yeah. Clearing out. We've got some good new vocabulary.
They're going to hate us in the office tomorrow.
Well, we're going to tell them all these new words.
Where'd you go? Rita, there is a Heartland connections group as well.
There you
that
go.
meets on Mondays at noon. And I don't have the flyers for that, but I can certainly send that to you.
Oh, that would be
as Anna would say, it's on our website. But
well, it is.
But if it comes to my email or my phone.
What's that?
When it comes to my email or phone, I've got it. I can get right there.
Sure.
First we had to learn because I am not a techie and I'm in remedial tech. But Zoom and, over the pandemic, we worked with a lot of clients to learn Zoom and become a little more proficient with technology. Mm-hmm. And like if somebody didn't know how to access one of like your guys' meetings or programs and they wanted to do it, that's something we would help them do.
Nice. That's great.
I may not because I'm not, but we have other staff who are much more technology proficient than me in the office.
So we do work from home. So Anna has an office in Neola, but but it's not always staff. So this is why, like, connecting with us via our emails or the website is the best way. The phone calls as well.
And that's what's going to be for me and Jimmy. We're going to be out in the community more and less in the office. So
we have the benefit of support staff in the office and have a bit larger team. So somebody's usually around. If not, support staff can field some of the calls and make sure we get hooked up with people. Where at first, I don't know that you guys are going to have that. You'll be out seeing your clients. So. Yeah.
It's a work in progress.
It is.
And if you need her and can't get any of them, you can always go through us and we know how to find her.
Well, you haven't brought your business card.
I have not.
That was very,
I will give you all my numbers to write down.
Yeah.
Always a day late and a dollar short. What can I say?
And I'm sure if we just asked, can we talk to Terry? Maybe
And the funny thing about that, we had a prescriber for many years whose name was also Terry.
Yeah.
And so we argued for many years about who was the better Terry, but they called us by our last names in the office. But now I'm the only one in there, so they'll know.
Yeah. That's funny.
Yeah.
She usually won because she had the prescription pad and I didn't. But I told him I was more fun than her.
Yeah.
Excuse me.
Excellent. Good.
Yeah.